Hi everybody, welcome to my channel. I'm Stacy, I'm a registered nurse. If you're new here, welcome in. If you're coming back, I'm so glad to have you. I was talking before about different levels of care and different care types that we have in hospice, and I think I would like to revisit that a little bit more in this video. And if you have any suggestions for things that you would like to hear about or questions that you have about hospice, I would love to answer those. So please just jot them down in the comments, type them in. Don't jot, because we don't jot anymore. We don't write with pens. I'm old. I just showed my age. But I ask that you like, subscribe, and follow for more if you have other things that you would like to talk about here. So let's talk about the different care types in hospice. We have what we call routine home care, which is what we see on a regular basis. Those are your patients who are what we call well palliated or hospice stable. Their symptoms are under control. They're kind of just going along in their disease process. There's nothing really changing immediately in those patients. And so they're routine home care. Those patients are getting 1 to 2 nurse visits a week, depending on their needs. They might be having some wound care, so they would be having maybe medication management, wound care. They're getting their vital signs assessed, any medication changes that would need to happen. Their meds are getting refilled by the nurse. So the nurse is typically seeing those patients 1 to 2 times a week at a minimum. Now, the minimum requirement is every 14 days, but we do like to see our patients weekly because, you know, a lot can happen and a lot can change in a week if you don't see your patient, especially if you have symptoms. A heavy debate is if you have a patient with symptoms, then you should follow up within 24 to 48 hours, just as a basic nursing standard of practice. I would like to stop here now and say that nothing that I say here replaces the advice of a medical doctor, and that everything that I say here is based on my own opinion and my own experience. So take what resonates with you and leave what doesn't, as the psychics say. Okay, so when we're talking about routine home care, again, we're talking about those patients that are well palliated, their symptoms are under control, and they're hospice stable. Stable is not something that we're using in hospice. They're not stable, but they're well palliated. So you're looking at them and their symptoms are well controlled. They have a good regimen and it's not needing any tweaking right now. Then we have continuous care patients. So a continuous care patient is a patient who is having symptoms and they would like to stay at home and have those symptoms managed. Some companies have a nurse that will come in and they'll rotate out in shifts until those symptoms get under control at home, until we get the medications titrated to a point where those symptoms are uncontrolled. Where those symptoms are controlled, not uncontrolled. So what you're looking at is probably an RN coming daily and an LVN or an RN, LPN, LVN, or an RN staying in shifts to administer the medications as ordered by the doctor in an effort to try to get those symptoms under control. A lot of times that looks like administering medications every 30 minutes to an hour to every 2 hours until we get the right dosage of medication to get somebody's symptoms managed. What kind of symptoms, you ask? That would be shortness of breath, pain, and it could be anxiety or agitation. You know, patients get agitated at end of life and in their disease process, and we do have medications that will control it. Sometimes patients with senile degeneration of the brain or different dementias or memory loss disorders where they are not able to differentiate what is happening anymore and they're not able to explain to you what's happening. Sometimes they have hallucinations, auditory hallucinations, visual hallucinations. They have agitation. They will slap the mess out of you. I'm not even kidding you. They will beat you up. They will slap you. That happens when people have dementia and sundowning, and that terminal restlessness can cause some terminal agitation too. And patients will scratch, bite, slap. They're trying to communicate something and they're not able to. It's like when a baby is crying and it's because their diaper's wet or they're hungry. People that have that advanced dementia are not able to tell you, I'm in pain, I'm hungry, I'm wet, I need something. so they become very agitated and restless at times. And so sometimes you'll need continuous care to manage those types of symptoms as well. I think I left that out when sometimes when I'm talking about end of life, but agitation is something that happens in people at end of life as well. So continuous care nurses will come into the home in shifts, and once those symptoms are under control, then we bring it back to a routine level of care. Now, routine level of care can also look like end of life, where the nurse is visiting daily, the social workers visiting daily. That is also considered routine care. Another level of care that we do in hospice is respite level of care. This is a tricky topic. Respite is to help relieve caregiver burnout. If you're a mom, a wife, a dad, a husband, a brother, a sister, and you are the primary sole caregiver of a person and you are with them 24/7, it can become very overwhelming. It can become very overwhelming. You're not getting sleep. You're not getting out to go see your friends. Maybe you're not even going to the grocery store. Maybe you're not even getting outside for a breath of fresh air. So respite is designed to relieve caregiver burnout, to give caregivers a break. It's usually like a 5-day period that Medicare allows. They go into a skilled nursing facility where they have 24-hour nursing available, and where nurses can, be monitoring them and managing their symptoms that would arise during that time. Respite is tricky because a lot of people want to use it frequently, and some people need it frequently. Some people really are the sole caregiver, and that monthly break, I have seen patients that truly need that break once a month. You can show it clearly. If a person is stressed, anxious, they're not sleeping, they're losing weight, they're not eating, they're carrying the sole burden for that person's care, they need a break. And as nurses and, social workers, and it is our responsibility, I was going to say, and chaplains, because chaplains talk to patients too about respite. It is our responsibility to say to them, hey, you seem like you need a break. What can we do to alleviate the stress that you're under? How can we help you? Because, sometimes it's just as simple as a person getting out and, going for lunch with their friends, or just having a few days where they can sleep all night. Because when a person is at end of life, the caregiver is not sleeping at night, especially if you can't afford paid caregivers. Some people have paid caregivers in their home, and the family gets to sleep at night, and the paid caregiver is the one staying up with the patient at night, dealing with those symptoms that arise at end of life, like pain, agitation, anxiety, and shortness of breath. That is scary. When you are not a medical person, for example, and you are dealing with somebody who can't catch their breath and they're panicking because they can't breathe, and you have to manage it and get it under control. Maybe you know how to do that, but it's exhausting, So we want to offer our patients respite. Respite is a level of care that we do for patients in hospice. Another level of care is general inpatient, which is your GIP level of care, and that's for patients with unmanaged symptoms that need to be put into a 24-hour nursing facility until their symptoms get under control. Maybe your hospice doesn't have continuous care available. Maybe your hospice has an inpatient unit. Maybe you have to transfer somebody off of the hospice that you work for to get them into a GIP situation. Ultimately, what GIP is managing uncontrolled symptoms. Every day you're looking at that person to see if there are any changes that need to be managed until that person gets palliated, until their symptoms get under control. So GIP is often in an inpatient facility. Sometimes nurses go into hospitals and see GIP patients. For example, at companies that I've worked with, you start the patient in the hospital, you have like a GIP situation where you admit them onto service, and they are in the hospital for a certain amount of time. If they are still with you, then they transition either to your inpatient unit if they're stable enough to transfer, or they transfer to their home if their symptoms have become palliated and they're able to be managed at home for routine home care. End of life in and of itself is not a GIP situation. Just because a person is in those active phases of dying doesn't mean that they're unmanaged or that they need an inpatient situation. But there are times when families just aren't capable of managing those end of life symptoms. They're just not there emotionally and they can't do it. So I have seen hospices bring a person in through those last few days of life where the family could have that 24-hour nursing, getting them through that death and dying process and making sure that those symptoms are managed, because it's really hard for some people to administer those medications and watch that process. You know, sometimes it's the first death that someone has seen. This is their loved one and now they're watching them die. And that can be really hard on a person that's never experienced that, or depending on, you know, the type of relationship. If you've been married to somebody for many, many years, or it's your child, for example, or your mom or your dad, you're losing a significant relationship in your life. And that can be really difficult to go through. So that is a level of care that we offer in hospice. So our levels of care are routine home care, which is the nurses coming into the home, everybody's coming into the home. So I have worked for hospice companies where the physicians actually go out and make visits periodically to recertify the patient. I have worked in hospices where the nurse practitioner does the recertification visits. So what you'll see coming into the home in home care situations will be nurse, social worker, home health aide, chaplain, sometimes a nurse practitioner, sometimes a physician. A lot of times the person you're going to see the most will be the nurse in that home care setting, because the nurse is reporting directly to the doctor the symptoms that are arising. I know that I have worked for companies where the doctor will do a FaceTime during the visit if you have symptoms that are unmanaged, where they can actually speak to the patient. And I tell you, the patients love that. If your doctor comes to the home or the nurse practitioner is coming to the home and they are getting that extra support and symptom management, I have worked with some really amazing physicians who will get on a FaceTime and chat with the patient and go through those symptoms with you and write the orders. Because, you know, sometimes that puts the patient's mind at ease. So those are the people that are coming in. Some hospices have other therapies involved, like music therapy. And I know some hospices have massage therapy. I would love to work for one of those hospices because a lot of patients have expressed that desire to have that massage therapy at end of life, you know, because there are adjunctive treatments that can be given with your prescription medications. And, you know, sometimes having those adjunct therapies involved with the prescription medications makes everything work together better. So I wish that I could see that more, but I know there has to be a strong need for it in most companies in order to have it, and a census to support that kind of therapy. But I would love to see it more. I would love to see it more, and I would love to be a part of a hospice that had those extra therapies. What I have seen is the chaplains offering that musical support in addition to their spiritual support that they offer. Another thing that you look at when you are doing respite, for example, the people that you will see will be facility nurses. There's facility doctors. A lot of times your doctor will actually go around in the facility where the patient is at respite, and you will have the nurse, the home health aide, and the chaplain and the social worker will come and see the patient while they're in respite. So when they go to respite, then they are getting that facility support plus the support of the team that's been giving them support in their home. So they don't lose that support once they go into a respite situation. When they are in a continuous care situation, again, they're still at home, but they're being managed by continuous nursing until the symptoms get under control. And then in your GIP situations, there's usually staff that is working full-time in an inpatient setting. But the case manager in some companies will go and still make a daily visit, or, you know, just to be checking in with the patient and verifying that that GIP status is still appropriate. So that's I guess that's all of it in a nutshell, in case you wondered what kind of things we do in hospice, what kind of levels of care we have. If you've ever wondered what respite was, what GIP means, because that's the lingo in hospice. So what are some questions that you have about hospice? I would love to talk about it in the comments. I would love to make more videos to answer your questions. And if you like what you see here, then I ask that you like, subscribe, and follow for more. And I thank you so much for watching, and I hope to see you soon. Bye-bye.